Several examples of progressive biceps instability and subluxation are shown, as in this first example in the right shoulder. With internal rotation, we can clearly identify a significant upper border subscapularis detachment. Note the wallowing slightly medially in the medial biceps fraying and intrinsic changes of biceps characteristic of a subtle subluxation. In the second example, left shoulder, there's again pathology in the subscapularis identified and even more of a vertical orientation of the biceps, atypical for normal anatomy. Again, we can see significant intrinsic changes in fraying of the biceps, and when we push the biceps, we can actually see it subluxate or dislocate. In this third example, a significant upper border subscapularis pathology is shown, and in fact, we can see the biceps tendon through the defect in the subscapularis. When we pull on this biceps, again, we can see significant changes in the biceps and a more vertical orientation. In fact, in this example, when we debride away the last restraining structures, which in this example is the superior glenohumeral ligament, we can watch the biceps spontaneously dislocate into this defect created by the absence of the subscapularis. In this most unstable example, we can see a large subscapularis tear and completely vertical orientation as noted upon entry arthroscopically. Management strategies to deal with the subluxated or dislocated biceps are shown here. One such management technique is to repair the subscapularis as shown here using standard suture anchor suture passage after excision of the rotator interval capsule as shown, but then also repurposing the sutures, which are not cut after subscapularis repair and are simply reused as shown here and are retrieved through the biceps so that the biceps can also be securely tenodiced in the same location as shown. Another different option for managing of subluxated unstable biceps is shown in this example is demonstrated. Again, we can see a significant upper border subscapularis tear with exposure of the lesser tuberosity. The debridement is carried out and the rotator interval capsule is excised again. In this example, an accessory anterosuperior portal is placed to help us manage sutures. And then in this example, instead of incorporating the biceps into the subscapularis repair, it is removed from the field. The subluxated biceps can often create complications for us in our ability to visualize and repair the subscapularis. The subscapularis is then repaired using anchors placed in the lesser tuberosity, and we can see a secure repair. After the subscapularis is repaired, the biceps can be then subsequently identified in the bicipital groove, and an arthroscopic tenodesis carried out is shown here. Note that the upper border of the subscapularis is repaired.